Okay, I'm hopeful that a few others are. I see the audio is trying to connect, but we're going to go ahead and kick off. Welcome, everyone. Good morning, good evening, good afternoon, wherever you are. We're thrilled that you're joining us for this session today. The aim of our session is to share innovative examples of improved counseling approaches that have been tested in Zambia, the Democratic Republic of Congo, and Nigeria that improve facility-based health workers and community health workers' skills in counseling that is really focused on deeply engaging with caregivers. So the objective today for our presenters is to exchange some promising social and behavior change programmatic approaches to reach children and improve nutritional outcomes. So we have three amazing speakers with us today. And the goal really is that we want to share some of the work that we've been involved in through Breakthrough Action, but in very close collaboration with the USAID Advancing Nutrition Project to apply some real innovation, we think at least, in SBC approaches to nutrition-related challenges. So Emily will kick us off sharing some of the insights in the work applying behavioral science. And then Dr. Shitu and Angela will share more around how we've applied human-centered design to some of these nutrition-related challenges. So Emily will focus primarily on counseling approaches from the DRC and Zambia, and Dr. Shitu, thank you, will focus on solutions that support community health workers in Nigeria, and their focus will be on complementary feeding. So just to note that, these examples were developed in tandem and very closely with health workers, facility-based health workers, as well as community health workers, and based on formative research to really develop localized and contextualized solutions. So please, we invite you to all share your questions in the chat as we carry on. And with that, I will pass over to Emily to share her screen. We won't be giving bios because you can find all of them on the website for the conference. So Emily, over to you.
Wonderful. Thank you so much, Lynn, for that introduction. And bear with me for one moment while I attempt to share my screen. Maybe just do a quick check that everyone is seeing that correctly. Lynn, if you could confirm.
Yeah, if you can make it a bit bigger, we're seeing some background as well. If you just make like maybe full screen.
How's that looking?
About the same. If you do full, there you go. And maybe to the right, pull it out, then it'll cover. There you go. Perfect. Thanks, Emily.
Excellent. Thanks so much. So thank you again, Lynn, and everyone for being here. I'm so excited to chat with you all about this topic today. I wanted to start us off with a really basic point that I know everyone in this room knows very well, but that I think is really important for us to keep front and center throughout my talk and the rest of today's session. And that's that quality counseling is really very much at the heart of good health services. And there's so much that counseling from a trained health worker can help to achieve for child health and nutrition outcomes. You'll see on this slide just a sampling of some of the things that quality counseling can achieve. It can support caregivers to feed their children according to nutrition guidelines. It can support clients to take or to give their children prescribed medications. It can help to overcome mistrust and counter myths that may exist in communities. It can motivate caregivers to take follow-up steps and to seek care later when it's appropriate. Can help to assure good clinical outcomes for clients, children, and families, and create positive and empowering client experiences that motivate follow-through and that motivate further engagement with health workers and the health system. And this is just a sample of some of the things that quality counseling can achieve. But I hope at the same time that just walking through these examples helps to illuminate how much counseling is asking of health providers and often of clients. And it's understandable that we see so much potential from what counseling can achieve, that we feel tempted often to cram as much as possible into a single counseling interaction, to try to get the most out of that interaction in a way that often tends to backfire when we try to fit too much in. So we also see that very often in practice, we're seeing mismatches between what we hope and expect that counseling from a health worker might be able to achieve and the practical reality of what happens. So we see job aids that steer providers toward very detailed and sophisticated messages that they're asked to convey to caregivers. And this is reinforced by other tools and materials, by the formative training that providers receive as well. We see that the practical reality of a health facility often involves really tremendous time pressures, a hectic environment where providers and clients' attention is stretched in many different directions. There's a lot that they're trying to achieve at once in a way that makes it really difficult to deliver and absorb these detailed, sophisticated messages. We see that clients can easily face challenges to absorbing the amount and the type of information that they receive, but they can also face barriers and challenges to putting guidance into practice related to their own sort of resources and ability to follow through. And we see very often, sort of connected to this point, that health workers sometimes doubt caregivers' ability or willingness to follow through on their guidance in a way that can be demotivating for providers to even bring up a topic at all if they expect that the client might react negatively or that the client wouldn't be able to put their advice into practice. So if we start thinking about solutions to help alleviate some of these tensions and mismatches, one solution that comes to mind is what I'll be terming bite-sized counseling in today's talk. And really at its essence, the idea of this is to distill counseling messages down to their bare essentials, to try to match messages to the extent possible to the moments when they're most likely to be understood and to stick, to make it as easy as possible for providers to deliver those messages and for clients to apply the guidance that they're receiving, and to focus throughout on what's most achievable for clients to ensure that clients are actually able to act on the counseling that they're receiving, and that providers feel motivated to deliver that counseling because they see how it can result in a practical change that's meaningful for a client's life. So with that stage setting, I'll spend the bulk of today's talk walking through 3 concrete examples from practice. And in each case, these were examples of activities focused on specific health and nutrition behaviors conducted by the Breakthrough Action Project. I will highlight a subset of the insights from the formative research that informed the solutions, and I'll talk in depth about the counseling approaches and tools that formed a part of those solution sets. I'll emphasize here that in each case, those counseling tools were only a part of the broader SBC solution set. And I'll come back to that point at the close of the talk with a few thoughts about how these bite-sized counseling tools and approaches can fit into more holistic program design and how they can be complemented by other approaches, other materials used through other touch points. So with that, the first example that I'll highlight focuses on exclusive breastfeeding. And this was work that was conducted in the DRC by Breakthrough Action as a part of its broader Viva social and behavior change campaign for health and nutrition. And the focus of this work was to support mothers to exclusively breastfeed their children for the first 6 months of life, something that we know is very important to health outcomes for children and also for mothers. This is a behavior where at the global level and also in the DRC, we see very significant gaps, and specifically that mothers do exclusively breastfeed their children for the first few months of life, but then drop off from exclusive breastfeeding around age 3 to 4 months. They continue to breastfeed, but also start to offer solid food and water to the child before the guidance suggests that they should. We conducted formative research in the DRC with mothers, with other family members, and with community and facility-based health providers. And you'll see on this slide just a subset of the insights that emerged from that formative research. So one finding was that mothers almost exclusively understood that breastfeeding was good for their babies. What they weren't consistently taking away from their interactions with health providers was a message about the value of exclusive breastfeeding. We saw that providers were very often focused on many other topics during the visits when breastfeeding could be discussed, and that often they didn't touch on this topic at all. And that when they did discuss exclusive breastfeeding with a client, they usually framed the message around when to start offering solid food, rather than emphasizing what not to offer during the first 6 months of the baby's life. And the result of this is that mothers tended to focus on the health benefits of breast milk, which they understood, and on the need to offer solid food, and that this message about the risks of offering anything other than breast milk for the first 6 months were sort of lost in some way. So this suggested that for solution design, we really wanted the counseling approach to be able to highlight this part of the message that mothers were often missing about the risks of offering solid food and water to a baby who is too young. So you'll see on this slide an example of one element of the solution set, which is a reminder sticker that providers receive that they can place in a spot where they're likely to see it during prenatal and postnatal visits and vaccination visits and other touch points when they may have an opportunity to discuss exclusive breastfeeding with a mother. This reminder sticker has an attention-grabbing header that reminds providers of that most critical, simple message about exclusive breastfeeding. And it frames the message in a memorable way by juxtaposing the benefits of breast milk on one side with the dangers of food and water to infants under 6 months on the other side. So again, making it as easy as possible for providers to deliver a very concise, simple message that highlights the part of that message that mothers are often missing. Here's another example of a sticker that explicitly connects the message to vaccination to make it feel timely and relevant during vaccination visits as well. Second example that I'd like to highlight focuses on feeding of sick and recovering children. And this was work also conducted in the DRC in close collaboration with the USAID Advancing Nutrition Project, focused on encouraging caregivers to continue feeding their young children during periods of illness and to offer them extra food in the 2 weeks following illness. And this is something that we know is tremendously important for both the child's recovery and to prevent malnutrition. There is relatively less research on this area in comparison to other complementary feeding behaviors, but the research that exists suggests that there are very substantial gaps, both at the global level and in the DRC where this work was conducted. Again, in this case, we conducted formative research with caregivers of young children, with other community members, and with facility and community-based health workers. We also conducted observations of interactions in clinics when feeding of sick and recovering children might be discussed. And a subset of the insights from this formative research are first that it very much highlighted that sick child consultations are a really promising moment to counsel on this topic of feeding in consistent with IMCI guidelines as well, but that providers are very often focused on other topics in many cases don't bring up the topic of feeding at all during these visits. We also saw that caregivers face many constraints in terms of what they're able to offer their children, both during times of illness and times of good health. They're held back from offering the types of food and the amount of food that they would like to be able to offer their children. And we heard consistently from providers that they often hesitate to bring up the topic of feeding because they anticipate that they may get a negative reaction from the caregiver, or that the caregiver won't be able to put in practice the advice that they're giving regarding feeding due to their limited resources. And finally, we found that caregivers tended to focus very much on specific foods that they perceived to be highest quality for their sick and recovering children. And they tended to assume that there wasn't much value in feeding more in general of available family foods to their children. And certainly quality of food is always important for young children, but we also know that during the critical moments of illness and recovery, the quantity of food that the child is offered is actually of paramount importance. And there's tremendous value in the child receiving more of available family foods, even if they aren't the specific foods that the caregivers might identify as highest quality. And this message was in some ways being lost, and caregivers weren't hearing this message clearly from health providers when they brought their children to facilities. So one element of the solution set is shown on the slide here. This is what we call a feeding prescription, and this is integrated into the consultation form that providers use during sick child consultations in the region. And this adds alongside the space for medical treatment, a small section that's focused on feeding during and after illness. It repeats the very simple, straightforward guidance that caregivers should continue to offer food and breast milk during illness, and to offer more food than usual in the 2 weeks after illness. It avoids mentioning any specific foods that may or may not be available to the family. And it contains some space for the provider to actually write in guidance based on the conversation that they have with the caregiver about what foods the family has access to and that they can offer to their child. And the aim of this is to elevate the importance of feeding alongside medical treatment, both for providers and for caregivers, to really highlight its importance in helping the child to recover from the illness. And again, to focus attention on what is within families' control and what caregivers can offer their children. This was complemented by a reminder sticker, and this works in a similar way to the ones that you saw in the first example, that highlights a very simple message that we know isn't currently coming through to caregivers during consultations. In this case, it is the empowering message about the value of a single bite in supporting the child's recovery, regardless of which food you're able to offer your child, and regardless of how much you're able to offer, that every bite counts during these critical moments. And this was something that we got very positive feedback on from both caregivers and providers, that this was really eye-opening to think about what they could do in these terms. The final example I'd like to highlight is from Zambia, and this was focused on encouraging caregivers to seek care in a timely manner for common childhood illness, which we know can save millions of lives of children around the world every year. Two of the insights that emerged from the formative research in this case are, first, that caregivers lack cues that indicate very clearly when they should take a child to the health facility. So they know when their children are sick, but sometimes struggle to make the judgment call about when the illness warrants taking them into the facility. We also learned that, especially for the lowest income families or the most rural families, that going to the facility is an incredibly complex and hassle-filled process. It involves expense, it involves coordination, and a lot of sort of things that caregivers need to figure out. And that in combination with that first insight, it makes it very easy for caregivers to put off bringing in the child to the facility, especially in cases where they're not entirely sure that it's necessary. So the solution here is actually a counseling tool to be used by a community health worker to explain the warning signs using very clear, unambiguous visual signals, and to guide the caregiver to identify who will seek care for the child and how they'll do that in the case that care seeking is necessary. And by laying out some of the details of the plan for how the caregiver will seek care, it helps to ensure that they'll be more likely to follow through in the moment, even in the face of the inconveniences and hassles that they might face to doing so. So I'll end with just a very quick point about how this fits into the broader ecosystem of social and behavior change solutions, and emphasize here that bite-sized counseling, almost by definition, needs to be matched to relatively narrow aims. None of the solutions that I highlighted today address all of the challenges and barriers to the health behaviors that they were focused on. There are partial solutions that were designed to be implemented in concert with other solutions that work through other touch points and at other moments to achieve complementary aims. I'll also highlight here that if you're interested in hearing more about the second solution set on feeding sick and recovering children, we do have a poster presentation that highlights all of the elements of that solution set. And finally, before I wrap up, I want to emphasize that it's certainly not the case that more expansive counseling is never warranted in a health facility environment or in an interaction with a health worker. Our goal shouldn't always be to distill messages down to their bare essentials, but really to think about matching what we're asking of providers and what we're asking of clients to the practical reality that they're facing, and making sure that the ask and the tools that they're using are appropriate for the moment. And in a moment, I will pass things over to my colleagues who will highlight and walk us through a much more sort of expansive counseling approach that was in that case warranted and appropriate for the setting. So again, we would really want to focus on kind of matching the tools and approaches to the practical reality. So thank you so much. Really look forward to the Q&A and discussion. And with that, I will pass things over to Dr. Shitu.
Thank you, Emily. As soon as you stop sharing your screen, I think your presentation really laid a good foundation for the one we're about to take on. Just let me share my screen. So good morning and good afternoon, everybody. This is a presentation on strengthening nutrition counseling among community healthcare workers in Nigeria in the hardest to reach areas, and coming up with some new tools to foster care and empathetic experience of care for caregivers and parents. This, as mentioned earlier, was work done by Breakthrough Action in Nigeria alongside Advancing Nutrition and Think Place. We all collaborated to implement this activity. This afternoon, I'll be presenting with a colleague of mine, Angela Samba, who was actively involved in implementing this activity. So by way of background, why are we focusing on complementary feeding? The incidence of malnutrition in the first 2 years of life has been directly linked with inadequate maternal breastfeeding and complementary feeding practices, along with high incidence of infectious diseases. So complementary feeding from 6 to 24 months is critical to young child nutrition and therefore lifelong growth and development. And we have data in Nigeria that suggests that 50% of children, more than 50% of children receive complementary food before they are 6 months of age. And a lot of the food they receive is low in terms of nutrients and doesn't meet the needs of the children, where breastfeeding the breastfeeding frequency has reduced. And as we all know as well, counseling on nutrition is common at health facilities and community level, and community healthcare workers are involved and recognized as a universal approach to improving complementary feeding practices worldwide. So what's the current situation with community healthcare worker counseling on complementary feeding? Right now, it's a very didactic approach. Community healthcare workers usually teach or tell caregivers what to do based on generic recommendations. And this does not allow for a two-way communication with the caregivers. And it's more of the community healthcare workers telling the caregivers what to do and just answering straight up questions without really looking at the specific context within which the caregiver is struggling with complementary feeding for their child. And there's also often a lack of trust between community healthcare workers and caregivers, and the current tools do not sufficiently address this barrier to quality counseling. Now, a little bit more about trust. This lack of trust, there are many reasons. One is community healthcare workers are normally from the communities where they work, so the community members don't see them as experts necessarily in telling them how to feed their children with complementary foods. There are issues around confidentiality. That's, again, because they feel that community healthcare workers know them, they may not necessarily keep things they share with them in confidence. And in many communities as well, we have where healthcare providers at the health facility may undermine community healthcare workers as less skilled workers, and that doesn't build the confidence of the communities to take what community healthcare workers say. And just by the way of a counseling relationship, the way community healthcare workers engage with communities, it usually doesn't give enough time for the trust to be built. And these are some of the reasons why there's a lack of trust between caregivers and community healthcare workers. So our goal was to provide community healthcare workers with a tool that they design themselves and find easy to use, meaningful and impactful when they engage in counseling on complementary feeding at community level. The focus question was, how can Nigerian community healthcare workers use the HCD approach? Went through the phase of uncovering challenges among community healthcare workers and caregivers together who had children they were feeding between 6 to 24 months. We analyzed those and found some insights, and went on to develop solutions, co-develop solutions with the community healthcare workers and caregivers themselves. We tested the solutions with several iterations, and coming back to improve and going back to test again. And we came up with a few solutions that we felt that were able to address some of the challenges to quality counseling that's provided by community healthcare workers. So in the first phase, we conducted qualitative research among a total of 183 respondents. These 183 respondents were cut across community healthcare workers, mothers and caregivers, community and peer group leaders, and household influencers. We used different methodologies. Remotely and digitally, we used a software called Engage that was developed by ThinkPlace, which is a social research tool used to collect qualitative data from the field. We also conducted desktop research and one-on-one interviews with some of the respondents that we engaged with. And some of the highlights of what we learned about the gaps in community healthcare worker job aids were the absence of support to build trust and empathy between community healthcare workers and caregivers. The tools that currently exist do not allow that personal connection to develop between the counselor and the counselee. And that space to create a bond, develop empathy with the client, with the caregiver, didn't really take place with the tools that existed. So that's ability to build trust and empathy was a huge gap because the tools were not designed to actually achieve that. And the tools also were not tailored to counseling specific situations. And that's why I liked the bite-sized counseling that Emily talked about earlier. With the tools that existed did not allow the counselor to understand the specific situation of the mother and the child and tailor to specific challenges or needs that the caregiver may have. This was also another gap we saw in the job aids. And then finally, most of the tools were addressing mainly the caregiver, the mother, and didn't also look at other players around the mother that influence the mother's behavior around feeding, like the fathers and the mother-in-law. So that was also a gap because mothers' feeding practices are influenced by many people beyond just herself within the socio-ecological model and in her immediate household and community as well. So these were the main gaps that we saw in the existing tools. We went on to develop solutions. So we had a couple of insights around trust and empathy, that inability to build empathy with the caregivers, uncertainty and fear among caregivers about the kind of foods they feed children 6 to 24 months. And there were a lot of food-based norms as well that determined what caregivers feed their children. We took these insights and developed, came up with associated solutions and related to the different insights that we found. We have a bucket here around relationship building, under which we came up with 2 prototypes around your own adventure and empathways. And we had another bucket of solutions around addressing knowledge and norms, where we came up with 2 additional prototypes, the card game and the trivia game. There were further insights around norms and the perceived value of local foods. Typically, caregivers feel the more expensive the food, the more nutritious it is for children, which is not usually the case. And then the confidence to introduce diverse foods was something that caregivers struggled with. Even if they knew or had the knowledge, they were not able to bring themselves to actually introduce new foods and try new things for their children. And there are 2 buckets of solutions here as well. We looked around attitudes, increasing the perceived value of locally available foods. Here we had 3 prototypes around price comparison and counseling flow. And then another bucket of solutions around confidence and agency, increasing the confidence to feed children diverse foods, where 2 other prototypes were able to address trivia game once again, and the counseling flow and action plan. We tested these solutions, these 8 prototypes with 66 members of 62 respondents to the study. We did this using focus group discussions, one-on-one interviews, shadowing, co-design sessions, and key learnings from the testing conducted was that the building block of that relationship is empathy. Once the community healthcare worker is not able to build that initial empathy with the client, pretty much everything they say from there is automatic, and the client picks what they can pick and may not necessarily get the full benefit of the counseling session. We all know empathy is good for health, and evidence shows that healthcare workers with empathy have patients that enjoy better health. And the goals of the tools we developed are to transform the interaction between the community healthcare worker and the caregiver or family and move from one-way communication to a more collaborative, 2-way session where both the community healthcare worker and the caregiver exchange information, learn from each other, and also be able to come up with solutions together to address the challenges of complementary feeding in that household. And that practicing compassion can improve the experience of both community healthcare workers and caregivers. So I'll hand over to my colleague, Angela, who will take us through the tools that we developed in this activity and how we use them to improve the quality of counseling that community healthcare workers provide to caregivers. Thank you.
Okay, thank you, Dr. Chita. So, next. So, like we said, we had tools that where we tested as part of the prototype, and at the end of the testing, we came back and improved on the tools, and these were the final tools. We had the main tool, which we call the nourishing connection tools, and then we also had supporting tools, which the nourishing connection supporting tools. So the main tools had 4 steps: the pathways, the assessing caregivers' knowledge, and the counseling flow and action planner. I'll just walk us briefly through the 4 steps. Next. So for the pathways, which is the first step, it the pathways is the where the counseling starts. It gives the caregiver and the community health worker an opportunity to interact so that they are able to build that relationship and make communication easy, such that the caregiver is the community health worker gives the caregiver an opportunity to also feel comfortable to share their experiences, and in a space that is not that is non-judgmental, and it also gives the opportunity for this two-way connected relationship that would also help build trust, and that way it will make it easier for the community health worker to provide tailored counseling and support for the caregiver's needs. This pathways also has steps. It has the pledge, where the community health worker encourages the mother and reassures the mother about confidentiality, and then the getting to know each other, where the community health worker shares their experience and makes the mother feel comfortable to communicate with them. And then you also have the information seeking step, and then finally the step for addressing needs. Next. For the next step of the activity, we have the assessing caregivers' knowledge on nutrition. And so this also provides a set of questions that would help the caregiver to place the mother in a category based on the responses the mother provides. So it gives the opportunity for assessing the caregiver's knowledge, attitude, and practice. So the questions provided would help the community health worker to know whether the mother's problems or the mother's issues are more around knowledge gap, so that the community health worker knows that okay, they can focus on providing the right information for the mother. Or if the mother falls within the practice gap, they also have supporting tools and opportunities to provide tailored counseling to support the mother to adopt some of the practices that the community health worker is promoting. And then if it's around attitude, the community health worker also has supporting tools that they could use to help the mother to address the issue around attitude as well. The next activity for this nourishing connection tools next is the counseling flow, and the counseling flow also has a set of questions that also helps to identify the current situation of the caregiver. But this time, beyond just identifying the current situation, it also gives an opportunity for the community health worker to identify and understand some of the barriers to practice of these behaviors, and also support the mother to adopt the complementary feeding practices that we're promoting. And in this using this tool as well, the community health worker can also use supporting tools to help in addressing some of the identified challenges. I will talk briefly about the supporting tools as well. So the next activity is the action plan. So this action plan, the community health worker would use this part of the tool throughout the counseling from starting with the pathways to using the assessing caregivers knowledge and also the counseling flow. So if there are specific actions, doable actions that they agree with the mother, they're documented here. And this would also help with prioritizing actions that the mother would take forward, and helps also the community health worker during follow-up as well. So this is the main tool. It has these 4 steps. But then you also have the supporting tools, which could be used to support the counseling or how the community health worker engages with the mother. So the supporting tools, next, the supporting tools are also, we had this orientation videos, which could be, the community health worker uses. So these orientation videos are videos of community health workers and caregivers expressing their experiences and their needs, and how community health workers have helped them to adopt practices, and vice versa. And also have you also have videos of caregivers talking about their experience with community health workers and how it has helped them to make good decisions about child feeding. So this also helps in building trust and making the mother or the caregiver relaxed, and feel easy to make it easy for them to communicate with the community health worker. Next. So some of the learnings we had from the testing, we also have the CHW's resisted sharing personal stories. So this was challenging because, like we said earlier, it was one of the reasons why there's issues with trust between community health workers and caregivers, because they live in the same community, and there's that fear of sharing their experience and then hearing other people talk about it. So it's something they had concerns about. But using the videos and also trying and seeing the benefits that came out from sharing experiences, we were able to get to the point where community health workers and mothers felt more comfortable to share their experiences. We also have some testimonies from community health workers that found this very valuable. Then we also have we also had compassionate counseling requires a different skill set. So we know that this is quite this tool is quite useful, but we know that for community health workers to adopt this, to use this tool, they also need a special set of skills. Their skills need to be developed. They need some trainings and some capacity building to help them to use these tools effectively. We also learned that gamification was a very good format for learning. People found it interesting, and it made learning easy. Just like we saw from some of the testimonies that were shared here. We had a community health worker that said the game is my favorite by far, and I don't need to ask for attention because everyone is paying attention without me making much effort. Next. Okay, so yes, these tools have a global relevance. They have global relevance. Next. So I will speak briefly about that. We know that empathy creates an empathetic counsel. It creates a two-way relationship building sets, which allows people to share their experiences and also allows the caregiver to feel more confident to communicate with the community health worker. And this is a skill that could help in counseling, not just for complementary feeding and not just in this setting, but globally, something that could yield good results using empathy in counseling. So the concept of empathy is something that is actually of global relevance. Next. the focus on 1 to 2 topics to solve timely issues is also something that is of global relevance. We saw using the counseling flow that CHW ask questions, and they focus on 1 or 2 topics that are most relevant to address the mother's need at the time. And it also helps them to identify the specific issues so that the mother's problems or needs are addressed, not just giving them generic information or generic counseling, but ensuring that counseling is tailored. And this is something that can be applied in any other counseling setting and globally to make counseling more effective. Next. So thank you.
Excellent. Thanks, Angela and Dr. Shitu. We have 2 other follow-on questions for you in the chat. The first is from Ikriti. Were the CHWs in Nigeria able to write? How well will the action plan section work in areas where CHWs have low levels of literacy? Would you mind speaking to that one first, Dr. Shitu or Angela?
Sure. The community healthcare workers that we work with in Breakthrough Action Nigeria are actually trained. They have basic education, so they can read and they can write. While the caregivers are not always able to read and write, we encourage them to document the action plans and also share a copy with them for those who can read and write. And some of them may actually have husbands or siblings or children that can read and write, so they can help them to remind them as well of the action plan that they committed to. But overall, definitely there are a couple of caregivers who actually just remember the discussion and what was proposed, and that's what they use to respond to the action plan. Not everybody is able to actually hold and read it, but a couple of them can do so.
Thank you, Dr. Shitu. And Karen has a question that reads as follows. How do you ensure adoption of these skills by CHWs? Did you include elements of supportive supervision to help CHWs grow and improve? So Angela?
Okay. Yeah. So okay, so what we were working on, even at the national level currently, we've added some elements of these tools into the national tools for training of CHWs and even health workers at the primary healthcare facilities to help improve their counseling. And like I mentioned earlier, this is something that requires a unique skill set. And so the continuous training, capacity building, supportive supervision is something that would really help the community health workers to adopt these practices and continue to improve on how they counsel. Thank you.
Great. Thank you, Angela. We have 10 minutes remaining. I don't know if there are any other questions. Feel free. I hopefully people can unmute or add additional questions in the chat. I have 1 or 2 more here, unless anyone else has another comment. Maybe while you're thinking, oh, please go ahead.
I saw a question. I saw a question on the poster presentation, and I saw that I think the person that asked the question is here. So she was asking if these concepts can be applied in other areas beyond complementary feeding. And I think that was one of the recommendations, and based on our learnings, we saw that yes, especially for supporting tools like the trivia as well, we saw that you could review the questions to accommodate some of those other behaviors so that those can also be addressed using this counseling tools.
Great. Thanks, Angela. And I wonder, I mean, if you or Dr. Shitu have any reflections on the human-centered design process and that co-development process that you may want to reflect on of, you know, the value add of trying that approach?
Yes, so co-development. Okay. Angela, you want to answer? Please carry on.
Okay, so let me say something, and you can just add to it. So yes, it's really important. We had a lot of learnings from using the human-centered design. I mean, there are lots of things that we could we would have assumed would not work if we had not tried working with these people to come up with these solutions. So coming up with these solutions, and like the questions that a lot of people would ask, would CHWs be able to use these tools? We had some of our fears and our worries and our concerns as well. But trying the tool, using a human-centered design, some of these ideas actually came from them. And we worked together with them to improve on the tools. We tested these tools with them, working with them, and that's how we got the final product. And I can say that, you know, if we had done this on our own, I'm sure that would not have the result we had, you know, in the end. But because we worked with the stakeholders, I mean the caregivers, the community health workers, and even the influencers, you know, we worked with their ideas, and it made it easy for us to come up with solutions that are tailored to their needs because they were part of the process. Thank you.
Thanks. And I'll just add that I think one of the biggest values of co-development is just having that cultural perspective that we get from the people that we co-design with. There are a lot of assumptions we come with as people who are not necessarily based in the culture, but those assumptions are challenged when we engage with communities, and then we're able to develop solutions with their inputs that takes into consideration some of the cultural issues, norms that we would probably take for granted when we think of solutions without actually engaging the communities we're trying to serve.
Thank you both. I also see that Emily had added in some of the nutrition job aids for CHWs from the Zambia experience, and we can add in the DRC ones as well. And really wanted to just call out and thank Lisa Sherburne and the USAID Advancing Nutrition Project and all of the colleagues there. This is very much a joint collaboration that has been incredibly fruitful. So we're grateful for that. I wonder, you know, for those, thanks, Emily. Thanks very much for adding that in the chat. So you can find the link, and they're also on the USAID Advancing Nutrition website, as well as the Breakthrough Action website. Just wondering from the group in the remaining few minutes we have, you know, do any of these tools that were developed in Zambia, the DRC, or Nigeria, you know, do you see any applicability to your own setting or your own country context? You know, they were all very much developed with the spirit of global adaptation that, you know, certainly local contextualization is needed, but would love to hear from anyone online if you see, you know, any potential opportunities for that in your country setting. And again, feel free to unmute or add any comments in the chat.
Hello.
Please go ahead.
I'm Raila Koru from Kenya. In Turkana County, the tools have been translated to the Turkana language, which is most of our CHVs, they understand the Turkana language than the Kiswahili and English. Thank you.
Thank you for that addition. Yes, again, local language and making sure that everything is clear is best practice. Any other thoughts or comments? And feel free, Emily, Dr. Shitu, Angela, I know we were trying to keep to time, but if there are additional elements you want to add, of course, feel free. I see a message in the chat from Leslie. Leslie saw similar issues around needing to build rapport, focus on very tailored conversations and empathy. Oh, okay, in the Kyrgyz Republic. Great, that's helpful. I think the role of empathy and compassion in client-provider interactions is really an important area to further unpack. Emily, please go ahead.
Yeah, thank you, Lynn. I was just reflecting on your earlier question about kind of involving caregivers and providers in the process. And I think something that really came through to me in all three of these processes for the examples that I highlighted was the importance of really understanding what's already happening, what providers are already covering very well with their clients, what clients understand and are already taking away from those interactions. So we're not starting from a blank slate of sort of what in the hypothetical we wish was covered in those visits, but really starting with what's happening and then thinking about ways to expand and enhance and improve and build on what's already happening. And that was something that we learned very directly from engaging with providers and with caregivers early in the process, and I think really strengthened the work a lot.
Thanks a lot, Emily. Thank you. We have 3 minutes remaining. Are there any other questions or comments or additions?
Hi, Lynn. This is Kelsey Torres from USAID Advancing Nutrition. Can you hear me okay?
Perfectly, Kelsey. Please go ahead.
Great. Yeah, thanks. I've been following this line of work, so I haven't been working on it directly with Lisa, but been learning a lot from it. And we aim to apply this idea of pathways to a flowchart that we have developed to help with counseling, to help streamline counseling and prioritize the children that are most at risk in Ghana. And this is part of our work to integrate responsive care and early learning with nutrition counseling. And so just to share some reflections that we had, and I'd love to hear others take on this, but as we were developing this flowchart and pre-testing and working with national leaders around getting their buy-in for it as we're pre-testing, we received some feedback around kind of better aligning with their protocols. And so this idea of introducing a new way of thinking about counseling or a new way to approach it, I think can be challenging to get uptake at the national level because there are protocols in place that they have had for a long time and that they follow. And so I'd love to hear the presenter's thoughts on how to get uptake for an innovative idea like pathways and get buy-in for it so that it can be integrated into the health system.
Great question. Thanks, Kelsey. Dr. Shitu or Angela, do you want to go first and then maybe Emily can respond as well?
So I'm not sure I fully heard the question. My connection was breaking, but I had the last part about integrating into the health system. And I think if you look at the way this tool is designed, this Nourishing Connections tool, I think it's really applicable at community level, but also at facility level, where we counsel cases of SAM and MAM that actually go to receive services. This approach can be used across the board at different levels of the health system. And I think even across disease area, like Angela pointed out earlier, because the principles are quite the same. You build rapport with the caregiver, find out where they are in terms of knowledge and attitudes, and then address specific challenges that they have and develop a solution that is tailored to them. So those principles are cut across beyond complementary feeding into other areas of intervention as well.
Thanks very much, Dr. Shitu. I think we are just at time now. So thank you everyone for joining us. Thanks again to Emily, Dr. Shitu and Angela, and our colleagues at the USAID Advancing Nutrition Project. Really appreciate you joining us today. And thanks to the organizers of the conference.
Thank you.